So I welcome you all on behalf of the Multidisciplinary Committee, AOGD. And today we will discuss about breast lump and fertility issues in breast cancer. And if we talk about the burden of the disease, then among Indian women, cancer is the commonest cancer overall and surpassed by carcinoma cervix. And in 2020, there were 2.3 million women diagnosed with breast cancer and 685,000 deaths globally. As of the end of 2020, there were 7.8 million women alive who were diagnosed with breast cancer in the past 5 years, making it the world's most prevalent cancer. There are lost disability adjusted life years by women to breast cancer globally than any other type of cancer. Breast cancer occurs in every country of the world in women at any age after puberty, but with increasing rates in later life. Prevalence of breast cancer in India in 2021, 1 in 28 Indian women is likely to develop breast cancer during the lifetime. It is more for urban women, 1 in 22, than in rural women. So nowadays, you know that now the breast is being commonly called as gynecological organ, and usually female get first opportunity to visit her obstetrician and gynecologist in her life first time. So we are the important person to diagnose this breast cancer early. And so it is very important on our part to make them aware about the increasing incidence of breast cancer, how to screen, what are the preventive strategies, and when to consult a breast surgeon. And prevention is the best strategy, and diagnosis at early stage is the most important. There are many non-modifiable and modifiable factors which we will discuss in details. And with this, first we will do a lamp lighting and then we will start our program. Shivam, please.
Arogyam dhana sampadah Shubham kurutvam kalyanam Arogyam dhana sampadah Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam Arogyam dhana sampadah Shubham kurutvam kalyanam Arogyam dhana sampadah.
Thank you so much, Shivam. Now I invite Dr. Achala Batra. Madam is the president of AOGD. And I like to request respected ma'am to kindly address the delegates and share the words of wisdom. Achala ma'am.
Thank you, Shashi, and good afternoon to all of you. A very nice sunny afternoon today after so many days. And first, I'm very happy and I would like to welcome people from outside Delhi, dignitaries who joined us, Dr. Kiran Pandey, Dr. Sneha, Dr. Milind Shah, and also Dr. Vedant Kamra, who is not a gynecologist. So big thank you for joining us. And like Shashi has already talked about the burden of disease and being the commonest cancer, but why we are lagging behind in screening is, I think probably because the females, they come to a gynecologist, the treatment is done by a surgeon. That is the reason, like in cervical cancer, we are so aggressive. We're doing so much, we are diagnosing and treating, but because we are not treating, surgically. So our screening, I think the fault lies with us that we are not screening so well for breast cancer. We are not so much aware. We don't talk so much about breast cancer, which is the commonest cancer. So I think this webinar is very pertinent in that we should at least know, how to screen. That's our job, because the female will never go to a surgeon. Indian female, they don't like going to a surgeon unless they obviously have a problem, then they don't mind going anywhere. But when they don't have a problem, they would shy from showing to just for screening. So it is, our domain, our duty, our call to screen the woman. And if she has a lump, how to go about it, we should know very well. So that I think is going to be discussed by Dr. Vedant Kabra. And then, when breast cancer occurs, and it's occurring in younger and younger females now. So there is an issue of fertility because she has to undergo chemotherapy. So we also have to know, what can be done for them. I think both the topics are very well chosen. I congratulate Sushila and Shashilata, Anita for having put forward this webinar. And I'm sure we are all going to take away very good take-home messages. Thank you.
Thank you so much, ma'am, for your wise words. And the essence of Madam's talk is that breast screening is now in gynecologist domain, and we must do it at every opportunity possible. So now I invite our guest of honor for today, Dr. Sneha Buhar. Please, Shivam, please display ma'am's, please display. Yeah. So Sneha Buhar ma'am is the chairperson of the FOXY, and she has done MD, MBBS and MD from Sassoon General Hospital. She has a teaching experience also from YNGMC Yavatmal. And ma'am, to her credit, there are lots of awards and accolades like National Individual Award by FOXY, Dr. Anandi by Joshi Award, FOXY President Appreciation Award, FOXY President Appreciation Award, Champion of FOXY, and many important posts she has held like Governing Council member, FOXY Chairperson, Breast Committee, Organizing Chairperson, Research, Talks and Publications. So I invite Dr. Sneha Buhar. Ma'am, I request you to kindly address the platform and share your insights with the audience.
Yes, thank you so much, Dr. Shashilata Kabra. And at the outset, I would like to thank Madam Achala Batra, President AOGD, and her entire team of AOGD for having this program and inviting all of us here. I'm very happy to share with you all, as Breast Committee Chairperson, because I'm so proud of all my members who are here, who are part of this program. My committee advisor, Dr. Milen Shaha, is also here. Committee National Coordinator, Dr. Charulata Bapai is here. And my committee members, Dr. Sushila Gupta, Dr. Sushma Sinha, Dr. Shashilata Kabra, Dr. Mrinalini Mani, and Dr. Anita Bajuria. All of them are part of this program, and all of them have put forth this wonderful program. And all of them are carrying such good work. May it be educational, awareness, and advocacy, and so many other types of activities they are always carrying. So I'm very proud of you all, my dear. And I welcome all the faculties, Dr. Vedan Kabra, Dr. Kiran Pandey, Dr. Swasti, and all of them from Delhi as well as from outside. I welcome all my members and all the delegates also here. Thank you, all of you, for having me here. Only I just want to say few lines from my side that yes, as Breast Committee, we are doing, we are working in 3 aspects, mainly the breastfeeding promotion, tackling benign breast diseases, and making awareness and screening in general public, so that we go ahead with early detection of breast cancer and timely referral to the surgeon. So I have always been stressing that we don't want to encroach upon the field. In fact, we want to do the timely and appropriate referral of these women, which can make the difference. As we are always saying that early detection saves lives. It's not the breast cancer which kills the woman, but it's the late diagnosis and the associated complications, the major surgery, and the advanced treatment what she requires is. And that's the very reason what our role is as gynecologists. We have to make it a point to examine the breast of each and every woman who comes to us for whatever her problems are. We have to examine her breast, notify if any abnormality is there, and if at all no abnormality, you have to teach her self breast examination, which she has to carry out every monthly after her menses, and she has to notify any abnormality. If no abnormality, she can continue to do this. If anything abnormal, she has to report to you, and then you can submit her to investigation. So we are the saviors, and that's why we are privileged, and we should utilize this window of opportunity. That's the only message we want to give to make a big difference. Thank you, AOGD,
Thank you, ma'am.
once again for having me here.
Thank you, ma'am, for your wonderful insights. I forgot to put Dr. Achala ma'am's CV. Ma'am needs no introduction. She is the president of AOGD, President Narchi, member of Urogynecological Committee, FOXY. She has contributed a lot in Government of India manuals, reviewer of index journals of Obs and Gynae. She authored many books in obstetrics and had set many papers in national and international journals. She is ex-editor AOGD, ex-editor Narchi, and Madam has an experience of more than 40 years. I again give thanks to our respected Achala ma'am for giving me this opportunity to organize this program under AOGD. Next, I invite Dr. Milind sir. Sir is our special guest of honor for today, and I request sir to share his wide experience on the subject. He has been working on this. Yes, sir.
Yeah. Thank you very much, Dr. Shashi, for this kind invitation. In fact, yes, this is the topic which is very close to my heart because since my practice 1990, I have noticed, yes, the breast actually problems always come in front of OBGYNs, and we should be aware of all that new happening, whatever happens in the field of breast cancer as well as breast lump. And that's why these two groups, both are very favorites of mine, Dr. Achila, AOGD, yes. I have been to AOGD almost 20 times. And that's why whenever someone calls me from AOGD, I get a very excited sort of mood because I know so many good friends of mine are there in the group. And Sneha as well, because yes, Sneha, you've done the change in the breast committee, so much actually innovation, so many of activities. It's really wonderful to see that the breast committee has become so vibrant now. And that's why the people are now more and more aware about these new happenings. I'm very sure that Dr. Shashi Kabra or Dr. Kiran Pandey, whatever they must have decided, the topics will give justice to the awareness creation, not only in the OBGYNs, but also other pathy doctors, because we must know what is happening new in this particular field. The talks which will be given by Dr. Vedant or the panel which Dr. Manalini and Dr. Sastry is going to conduct, I'm very sure that will give us good insight because yes, because of diagnosis, the younger age women also are diagnosed with at very early stages of CA breast, whereby we want to sponsor actually their breast as well as their fertility. And that's why all these panelists, when I was going through the list of Dr. Sushila, Dr. Sushma, Renuka, Charulata Bapai, working very hard for this particular field, Safalta, Punita, Puneet, yeah, they're going to speak a lot about this particular fact. I'm very sure they will touch upon the diagnosis part of it. Basically, the mammography, which you always used to say about a lot, but when now we understand the limitations of mammo, and now it is complemented by sonosalpingography, sorry, the sonography, elastosonography, whereby we can complement these two actually things, the mammo as well as the sonography to detect very small lesions. At the same time, the FNAC, which was very popular once upon a day, now we understood the truncated biopsy is far better, whereby the diagnosis can be more accurate and we can reach to the diagnosis accordingly and take it further. So it's a great actually event, I would say. And I'm so happy to see Anita as well after a long time because we used to communicate a lot whenever I used to come to Delhi actually for various meetings. We are missing the personal physical meetings, but now we can definitely enjoy meeting each other through virtual and we'll have to accept that fact as a new normal because we understood there's no way out for this pandemic because of these repeated waves of pandemic which are coming up. When it comes to the surgery, I know that the conservative surgery was not very popular. Immediately, people, the women used to undergo either mastectomy or the modified mastectomy, but now we can conserve almost more than 50% of the CA breast patients' breast. And that's why this knowledge needs to get percolated to all those people. This is the only cancer where the hormonal therapy is very important and plays a major role. But those hormones can affect the reproductive functions of that particular woman, and that needs to be tackled very carefully as a multidisciplinary approach. So I'm very sure this webinar would be a wonderful treat for all of us, and we want to listen to each and every one of you very carefully to increase our knowledge as well. So thank you very much once again, Dr. Shashi, Kiran, Dr. Achla, and Dr. Sneha for this wonderful opportunity to interact with you all. And I'm very sure that this is going to go a long way. I wish every success for this particular webinar. Thank you very much for the invitation.
Thank you so much, Dr. Milind sir, for honoring us with your presence and your wise words.
Thank you.
So now I invite Dr. Sushila Gupta, coordinator along with me. Ma'am is a director and senior consultant to Ops and Gynae at GNH Hospital Shalimar Bagh, and she is a mentor of Multidisciplinary Committee. She had been advisor of DGF North in 2018, chairperson of Breast and Cervical Cancer Awareness Screening and Prevention Committee 2018 and 20. And she has received many awards like IMA Luminary Award, Women Achiever Award, APJ Abdul Kalam Excellence Award. So over to you, Sushila ma'am.
Thank you very much, Dr. Shashi, for the kind introduction. I welcome you all, especially Dr. Milind Shah, Dr. Sneha, Dr. Achla, taking time from your busy schedule. And I welcome everybody side, my audience and my colleagues, also my friends, and special speaker, our Dr. Vedant Kabra. And I'll just say one word, these multidisciplinary approach and multidisciplinary webinars, they are, or semi-CMEs, they are very, very important, because as everybody is aware and Dr. Achla has said, like breast is basically not comes in the gynecology curriculum, but now we think Dr. Sneha has already done so much work that breast is also a gynae organ. We should also study for the, because every patient, whatever is the element related to the breast, they are coming to the gynecologist only first time. So these CMEs are very, very important for our doctors colleague and as well as our society also, so that we can give right information to society and our patients. So without any delay, I'll now invite my chairpersons for the first speaker, first talk given by Dr. Vedant Kalra. And first chairperson of this talk is Dr. Shashi Kabra. Everybody knows she is very, very enthusiastic, very, very active member of the FOXI and the AOGD, and she is working so hard. And the best part, what I have seen her, she has organized more than 50 workshops in PPH, and she has like designed the simulators also, surgical simulator also. That is very, very good work she has done. And she is a chairperson of the multidisciplinary committee, and she has a long list of awards. And now I invite my second chairperson, Dr. Kiran. Dr. Kiran Pandey, first of all, she's very, very good friend of mine. I'll take proud to invite her. And she's head of the department for the last more than 18 years, Kanpur Medical College. At present, she is a ICOG governing governing council, and she is a president of Kanpur Menopausal Society, and she had been president of Cox and IMA. There is a long list of award, and she has worked so hard, and I must say she is dedicated to the OBGYN, and I really congratulate her whatever she has done, and I wish her to be successful in her all future endeavor, and whatever she wants to achieve, she should achieve. I must say she should achieve the higher and the highest post in our gynae society.
Thank you.
Now I welcome Dr. Kiran. Just Dr. Kiran, I'll request you to introduce our first speaker, Dr. Vedant.
Thank you so much for your kind words, Dr. Sushila. Over to Dr. Kiran.
Thank you. At the outset, I would say many thanks to Dr. Achla for giving me this opportunity in AOGD, and the whole team, Dr. Sneha Buyar, who is the chairperson breast committee and has been working so hard, Dr. Milind, so committed and passionate about breast cancer, and Sushila, she was the person who is, so spoke so kind words for me. I'm very thankful for your future wishes. So I will introduce Dr. Vedant Kabra, but before that, I would like to say one word. This idea of multidisciplinary committee actually intrigued me. It's a very nice committee, and it's the working where everybody is coming at a one platform. Dr. Achla and I think the whole team needs appreciation for this. I will in fact encourage in Cox such type of committee and work more for it, where we can work together. Thank you so much once again, and let's talk about Dr. Vedant Kabra, such a learned and eminent speaker, Principal Director, Department of Surgical Oncology, Fortis Memorial Research Institute, Gurugram, India. Dr. Vedanta, he has done surgical onco training from Tata Memorial Hospital, Mumbai. He has many fellowships and overseas experience at National Cancer Center, Singapore, tissue biobanking course, Belgium, robotic surgery certification from USA, Sunwell. Many awards to his credit: University Gold Medal, Final MBBS, Best President Award, Best Research. You can see from very beginning, he is very academic. And academic activities besides this, he's an ex-faculty at Indo-British Breast Oncoplasty Fellowship course even now. He has written 4 book chapters and several peer-reviewed publications, faculty at national and international conferences, and has a surgical oncology experience of 25 years. Dr. Vedanta, I'm very much impressed by your CV myself. So nice to, and I'm really eager to listen to your experiences and your views. Already a lot has been talked about the importance of breast cancer screening, and let's see how we can screen out the risk factors and how the gynecologist and the oncologist together work in this field. Thank you.
Thank you very much, Dr. Pandey, for those kind words. And in fact, I have a little association with Kanpur also, when I had come there for Dr. Tarachan Memorial.
Yes, I do remember.
In 1996.
Yeah, I have been in IMA also. I've been president there. So I do remember that you have been into this also. Very nice.
So I'll share my screen and we'll start the presentation without further delay. First of all, very good afternoon, all members of AOGD, dignitaries from Foxy, and some of my colleagues from Oncology Fraternity who I can see on the screen. It's nice to see you here. And as everybody has pointed out very well, that most of the patients who have breast issues would first point of contact would be a gynecologist. And it is very important, as my previous speakers have already told, that we must reassure our patients, because most of them, almost 7 out of 10 lumps are going to be benign. But before reassuring them, we must rule out that there is no malignancy there, and we must investigate them, whatever is needed according to their complaints and the character of the lump. So this is the flow of talk that I'll have: clinical evaluation, then imaging, pathology, then we join the dots, and which is called as triple assessment of clinical, imaging, and pathology, how we join them together and then achieve a conclusion. There are certain do's and don'ts, especially while doing surgery for breast lumps, and then certain clinical examples of how to tackle them. The goal, basically, the goal of assessment of a breast lump is to exclude or to confirm the malignancy, one of these two. We must provide a diagnosis to the patient, and we must also provide an explanation for her complaints or for the diagnosis, and then how to go about treating it in future. Please remember, we must prove all the lumps to be benign before we decide to observe them, whether they are by imaging features or they are by utilizing cytology or pathology. Just by clinical examination, we cannot exclude malignancy and cannot send the patient home saying that this is nothing and it will be fine. We must utilize at least imaging, and if required, then pathology as well. Starting from history, there are certain red flags. If the patient herself is complaining that it is a hard, irregular lump growing in size, there are some changes which she has noticed in skin or nipple, and there are nipple discharges, especially if it is a serous nipple discharge or it is a bloody single duct discharge. These are the most sinister discharges, and we must be cautious in dealing with such patients. Those who are having dirty kind of greenish discharge or having milky discharge are unlikely to have malignancy. The best way to see the color of the discharge is to see it on a white piece of cloth or a white piece of tissue, because that will show you the right color. Most of the time, patients with a darker discharge would say, "Doctor Sahab, blood aa raha hai." But when you see it on a white tissue, you will realize it is a dirty kind of greenish discharge, which is of duct ectasia and is unlikely to be associated with malignancy. So that's the best way to see the color of the discharge. It goes without saying that we must take other histories, especially family history of previous breast biopsies or diseases, because certain breast biopsies have been done. Patients have forgotten to see the biopsy report when it was probably malignant, or it was a pre-malignant lesion or a high-risk lesion, which would increase the chance of malignancy in future, and systemic assessment as we do for any other patient. A physical examination again becomes very important. Exposure also is very important. A lady coming to a lady may not hesitate, but when they come to us, many a times they hesitate in exposing completely. We must expose from waist up, because all parts of breast need to be examined very thoroughly. Axilla needs to be examined. So if they just take their cloth up and do not remove it completely, you will have challenge in examining the axilla. We must examine them in supine and sitting position both, and systematically every part of the breast. And finally, we should document our findings, preferably with a figure, which I'll show in subsequent slides as well. Now, in physical examination, there are certain red flags which should alert us in doing the more thorough investigation. If there is a asymmetry in shape or size of the breast, both the breasts, if you compare one with the other, any asymmetry in the nipple, there is inversion of nipple, retraction of nipple, or destruction of nipple, and I'll illustrate most of them with photographs. So if you see this, there is a gross asymmetry in size as well as shape and the nipple level. The right side breast is pulled up completely and has become smaller as well. Here you can see there is nipple retraction, which is not complete but mild retraction, and there is partial destruction of the nipple also. This is very evident nipple deviation on the left side, and this is nipple inversion. So these are various abnormalities that we can find. There are going to be some ladies who have nipple inversion or nipple retraction right from the puberty days, and that is not a problem. But a recent inversion or a recent retraction is definitely a cause of worry. Sometimes it can be seen in chronic inflammatory diseases, chronic granulomatous diseases, but largely it is a sign of malignancy. Now, skin retraction, tethering, edema, inflammation, ulceration, or satellite nodules. These are again very strong signs of malignancy, and each of them have a different meaning. Now, this lady apparently looks like both the breasts are fine. There is no abnormality. But when you ask the lady to raise the hand, you realize that there is some asymmetry on the left side. And on a closer look, there is a clear-cut skin retraction seen, which is because there is a lump inside. So if we do not examine the patient by taking her hand up and we examine only with the hand by the sides, we may miss this finding and we can send the patient off. So I have had at least 2-3 patients who had subtle signs, very small lump, but there was a skin retraction because this lump was close to the inframammary crease, which is the case for this lady also, and were missed by people who examined her earlier. Now, there is a skin dimpling you can see on the top side, outer half, or at the 12 o'clock position. If you come to around 2 o'clock position, you will see skin is tethered to the underlying lump. So the same lump is causing skin tethering in the proximity of the lump and skin dimpling a little far away from the lump side, and very early nipple retraction is there. These are very gross findings and nobody can miss it. But this is how we do get some of the patients still even today, even in private practice. In public hospitals, you see such kind of patients much more often, but we see them in private practice as well. Now, what is the character of the lump, and is there a lymphadenopathy present or not? These would again decide it's a hard lump, irregular lump, which does not move very freely within the breast. These are the characteristics which should alert our mind towards malignancy. And this is how I would document. I may not use different colors, but I've made an illustration here just to show but 90% of my patients who come with a breast complaint would have this diagram on my prescription. This will show, so the red stippled line on the right breast is the lump, measured in 2 dimensions at least and documented on paper. Lymph node in the right axilla, and on the left side you can see stippled black line. This is just denoting that this is a dense area of the breast, and most of the time you find in younger ladies upper outer quadrant which is dense, and we should notice it, we should document it, and we should reassure our patients that this is nothing, because they will come with a big lump here and you find that this is nothing but just a dense breast. So just to summarize how to go about with breast lump physical examination, you find no abnormality, you can reassure the patient. However, with age appropriate thing, you may ask for certain imaging, at least an ultrasound, and in an older lady, a mammogram if it has not been done very recently. If there is a thickening, you examine and you don't find anything concerning, you can reevaluate in the short term or ask for an imaging. If it looks clinically benign, definitely ask for imaging and then take a call whether to do a biopsy or not. If it is clinically suspicious, then imaging as well as biopsy will be done. So imaging, first thing which comes to our mind is mammogram. This is the standard of care for any clinical abnormality that the patient presents with if she is over 30 years. And if she presents with a lump, we should do a mammogram. Otherwise, for a screening mammogram, it should be done only after 40 years of age. But somebody presenting with a clinical abnormality, we can do it even after 30 years of age. Nowadays, we don't ask for mammogram alone. Most of the time, we'll also ask for a complementary ultrasound to see the character of the lump. It should also be done even if malignancy is proven. I have seen patients who have a biopsy proof of malignancy in the breast. They will come with a PET CT scan, but a mammogram has not been done, which is wrong, because there are certain things which can be seen only on a mammogram and will not be seen on PET CT. So PET CT is not a substitute of a breast imaging, whether it is MRI or mammogram or ultrasound. It should be always bilateral. A lady comes to us with a right-sided complaint, we can't ask for a right-sided mammogram only. It should always be done bilateral, and at least 2 views are done, which is mediolateral and craniocaudal, with some additional views required in some patients where they take a magnification view, what we call as cone magnification view. Nowadays, instead of a plain mammogram, there is something called tomosynthesis, which is like sectioning the breast into various planes. You have multiple films instead of just 2 films, and which is good for a dense breast. We should preferably ask a radiologist who has been doing a lot of mammograms, who has been studying a lot of mammograms and has experience in reporting. And there are 2 grading systems which should be reported for all breast imaging, which is BIRADS and ACR. BIRADS is basically what is the suspicion level, and ACR grading grades the density of the breast. Early ACR grade of A and B are okay. C and D is very dense breast. And if it is a film that comes to us, we should have a hand lens to examine it. These days in hospital, we have PAC systems, so you can enlarge, you can zoom in and see it very nicely. Don't need hand lenses for that. The indications for mammogram, one of them I've already told you: palpable mass or a suspicious thickening in a lady over 30 years of age. There are skin changes or inflammatory breast findings, which could be because of inflammatory breast cancer or a breast cancer which is coming to the skin. There is axillary lymphadenopathy, but with normal clinical breast examination. So it's an clinically occult breast primary with axillary lymphadenopathy, which is suspicious for malignancy. Newly diagnosed breast cancer. Symptomatic males. So this is not so relevant here because male patients would not come to you, but breast cancer happens in males as well, and mammograms can be done in males also. If they report a lump and if they have even a mild gynecomastia, they can be subjected to mammogram. And finally, which is probably the most important, is screening mammogram. But there are certain red flags in mammography as well. The shape of the tumor, which could be irregular or nodular, to suggest higher chance of malignancy. The margin would be spiculated, not very distinct, or micronodular. And then calcification. There are many types of calcifications which we see on mammogram, and can be falsely labeled as microcalcification. But the one which is most suspicious is a clustered pleomorphic microcalcification. It is either a linear or a linear branching pattern, and I'll show you certain photographs also. Most of the time, microcalcifications need a hand lens to be seen very nicely. Now, this upper mammogram, it's obviously a magnified view. You can see a very spiculated margin and a pleomorphic kind of microcalcification. This is a zoomed up. That is why you may say that it is a macrocalcification, but it's actually a microcalcification. On the screen left lower side, you can see there is an irregularity in the margin. And on the screen on the right side, you will see extensive microcalcification involving almost half of the breast. Quite a dense breast, this one, and will probably also need MRI to rule out any other mass in the breast. Now, architectural distortion and skin thickening. There are sometimes subtle architectural distortions seen within the breast without seeing a mass. This lady, you can see both sides. On the right side, there is a gross thickening of the skin shown by this arrow. And if you compare with the opposite side, it's almost 2 to 3 times that this skin is thickened. How do we grade the mammogram? BI-RADS 0 means it needs further assessment, and this simple mammogram is insufficient to tell us about the abnormality. When does it happen? Usually happens in a dense breast. BI-RADS 1 and 2 are either a normal finding or a benign finding, so we need not really worry about these so much. If clinically also it appears benign. BI-RADS 3 is probably benign, and there is a small percentage chance that it may be malignant. BI-RADS 4 and 5 are very suspicious, BI-RADS 5 being almost 95% chance of being malignant. And BI-RADS 6 is a mammogram done in a proven malignancy. Ultrasound, I have mentioned earlier also, it has a very important role. It's a very accurate tool also. It can characterize the masses. We feel the lump, we feel it is solid, but then ultrasound may say, oh, it's just a pure cystic, simple cyst, and we don't need to do anything. In a dense mammogram, ultrasound helps us to detect multicentricity of the tumor. So in a dense breast, you may not find another lesion on mammogram, but ultrasound will say, no, there is another lesion in a different quadrant, which is multicentricity. And ultrasound also characterizes lymph nodes better. Some radiologists would go on to report lymph nodes on mammogram, but you cannot characterize a lymph node on mammogram. You should not be reporting it as metastatic on mammogram unless they are really huge. So characterization of lymph node is best possible on ultrasound, and it can also be used as guidance for biopsies. These days, most of the time we ask for ultrasound guided biopsies. I would not hesitate in doing an unguided biopsy in a very well palpated lump, which is a homogeneous kind of lump. If it is a partly cystic, partly solid, necrotic lump, then I would prefer an ultrasound so that biopsy can be taken from the right place. But for a homogeneous lump, very well palpated, superficially felt, I would not hesitate doing an unguided biopsy also. We must remember that a sonologist should be meticulous and skillful. Just a perfunctory ultrasound will miss a lot of findings. Ideally, they should also be skillful enough to perform needle biopsies or localizations. So there are some impalpable lumps or impalpable lesions which are detected on screening mammogram. They are also seen on ultrasound. We can't feel them. We need to localize them with a wire before we can operate. BI-RADS reporting should be done. And again, both breasts and axilla should be scanned. You cannot scan just breast and leave the axilla behind. If you get such a report, my request is please send the patient back to the radiologist, ask them to scan both the breast, ask them to scan axilla and report on that. Again, indications to characterize a mass, distinguish from lumpiness. So there are lumpiness reported many a times. Patient would come, I have a lump, but you don't feel a lump. You just feel there is nodularity and could be just a breast density. Or MRI detected mammogram occult lesions where we ask for second look ultrasound, because if it is not seen on mammogram, it is detected only on MRI and not seen on ultrasound also, we will need a MRI guided biopsy, which is not available very freely at not at many centers. Only 2 centers in Delhi NCR are doing it. So we ask for a second look ultrasound, and after MRI detection, if you do a second look ultrasound, there is a fair chance that you will be able to see that lesion even on an ultrasound. If it is still not seen, then MRI guided biopsy. So final is for guided procedure also. Now there are certain ultrasound pictures that I want to show. These are very clearly benign. On the left side of the screen, it's a simple cyst, black colored, clear fluid inside, no wall thickening, and no septae, no solid component. On the right side, looks like a fibroadenoma. It's a smooth lump. The vascularity is not there. I'm not showing the Doppler one, but the vascularity is not there, and it's absolutely homogeneous. Clinically, it was a mobile one. Now you see this one is an irregular margin and is casting an acoustic shadow behind. Very suspicious lump. This again is a suspicious lump because there is micronodularity, there is irregularity of margin. Sometimes you can see this in a fibroadenoma also, but such lumps cannot be left behind without doing a biopsy. The first two, the top two photographs, especially the cyst, you don't need to do anything. But for a fibroadenoma on imaging, it is better to do a needle biopsy, prove it to be a fibroadenoma, and then observe it. Unless it is very small, maybe you can just observe by imaging. Now, MRI usually is a problem-solving imaging. In cases of equivocal mammogram, ultrasound, or physical examination findings, so you are not sure, or there are discordance between your findings on clinical examination and imaging, then MRI can be a problem-solving tool. In an axillary node malignancy with unknown primary site, I mentioned, I mentioned this as an indication of a mammogram as well. If you don't find anything on mammogram, then MRI is the next step. Staging the disease or finding multicentric disease. Staging because MRI is quite sensitive in characterizing the lymph nodes, just like an ultrasound. And it will find multicentric disease in a dense breast. So a dense breast on mammogram, if we are planning breast conservation surgery, it's best to also do an MRI before we do breast conservation, lest we miss another lesion in another quadrant, which leads to a recurrence later on. And high risk screening. So those who are BRCA positive will not only require mammographic screening, but also MRI screening. So BRCA positive ladies or other high risk ladies would need screening by mammogram as well as MRI every year. What we do usually is we don't do both of them together. We space them 6 monthly. So mammogram is done now, 6 months later MRI, 6 months later mammogram, and again 6 months later MRI, and so on. So this way you have a chance of screening the lady twice a year. Now this is an example. I've not shown the mammogram here, but mammogram was showing only one lesion. And you can very well see on the left half of your screen, there are at least 3 or maybe even 4 lesions in this lady, and she is definitely not suitable for a breast conservation. And this is how MRI helps us in a dense breast. Now, coming to pathology, there are various options available to us: FNAC, core biopsy, vacuum assisted biopsy, incisional biopsy, excisional biopsy. I have put core biopsy or true cut biopsy or a gun biopsy in red because that is the most favored and most recommended way of knowing a pathology of a breast lump. FNAC is not to be recommended usually for various reasons, which I will tell you later. Now, FNAC is very easily performed, is readily available, less pain, less ecchymosis, and less chance of hematoma after the procedure. However, there are problems because material can be insufficient, so the accuracy is low. If the pathologist is saying it is malignant, the specificity is good, but the sensitivity is no more than 70% in hands of good pathologists also. They cannot comment on the invasive character. Again, this is a fallacy that we see very often. Pathologist has done FNAC and they will report infiltrating ductal carcinoma. It's simply not possible to report on invasion only on FNAC. Also, in today's era of personalized medicine, when we have to know estrogen receptor, progesterone receptor, HER2/neu, there are various markers, which is not possible on FNAC. If we have a very good sample on FNAC, cell blocks can be made and those typings can be done, but they're not so reliable, and it's best to do a core biopsy. Also, you need a very experienced cytopathologist, which are not easy to get everywhere. Who should do an FNAC and how to do it? Pathologist would say, I want to do it. Radiologist says, I want to do it. And the clinician wants to do it herself or himself. Anybody who knows it can do it, but please do it in a proper manner. It is best to send the patient to a pathologist. Let them do it so that the chance of them saying that inadequate sample is there is minimized. Core biopsy obviously has a better accuracy because you're giving a tissue. You get much more amount of tissue. This is the current standard of care, and always ask for a core biopsy. Don't ask for a FNAC. There is some discomfort, but it is done under local anesthesia and usually is almost painless. Cost is higher because we use an equipment. There is a gun. Also, it is a tissue processing. So histopathology versus cytology would be slightly more expensive, but this is justified because we get much more information. So it's a local anesthesia, hardly a 2 mm cut. We usually use 14, 16 gauge needle, 18 gauge, we don't use anymore. And it's a 10-minute OPD procedure. This is how it is done. You can see in the upper picture that needle has gone in. In the lower picture, there is a long length of tissue which has come. So almost 2 centimeter long course can come. Usually 5 mm, 10 mm, or up to 20 mm course can be obtained with a gun biopsy. Now, how do we join these dots? There comes the role of triple test. And we have to see that clinical part, clinical assessment, radiologic assessment, and pathologic assessment, all three are needed for solid masses. There comes the role of multidisciplinary team, because you need a clinician, a radiologist, and a pathologist. And it was also well brought out by some of the dignitaries that it's now a multidisciplinary management for most of the diseases. If there is a discordance between the tests, so suppose the radiologist said BI-RADS 5 and the pathologist is saying, no, it's a benign thing, we have to repeat a biopsy. If pathologist is saying that the biopsy is likely to reveal the same thing, we may proceed with an excision also with a frozen section control and a preparation for doing a definitive surgery in the same go to avoid another anesthesia. One more point, if there is a papillary lesion or a papilloma reported on radiology, please do not ask for a core biopsy, because the pathologist will not be able to differentiate between a papilloma and a papillary carcinoma on a core biopsy. They would like the whole specimen to be sent to them. So this is one situation where we do not recommend FNAC or a core biopsy. We straight away recommend an excision, because they need the whole specimen for them to clearly tell us or differentiate between a benign and a malignant papillary lesion. Now, what not to do? This young lady, head end is on the right side. You can see where the lump was. This was excised with a periareolar incision, which is also marked here. And after the excision, there was a drain put at the inframammary crease. So they have violated the plane of the whole breast. Firstly, after the excision of such a small lump, you do not even need a drain. If the hemostasis is okay, you don't need a drain. Even if you have to drain it, please drain it just next to the scar so that the whole plane is not violated. This turned out to be a malignancy. This young lady obviously wanted breast conservation, was suitable for it because this was the only lesion, but we could not do it because the whole breast was violated. Similarly, this lady had a scar which was going almost outside the limit of the breast. As a result, when she came for a definitive surgery, which was a mastectomy, and again, you can see there is a drain in the lower outer part, which is again far away from the excision side. So what we needed to do was we had to make a very big ellipse, which was going way beyond into the axilla while doing surgery. And when this lady requires radiation later on, they have to cover the whole scar. And this goes into axilla and even at the back. So radiating a larger area, radiation going to axilla, which is going to increase the chance of lymphedema quite significantly. So we have to be very mindful when we are taking the scars, taking the incision for a breast lumpectomy, thinking about future. What if it turns malignant? What if this lady requires a breast conservation? What if this lady requires a mastectomy? Am I taking the scar way beyond the boundaries of the breast? I'm sorry. This is a similar kind of flow chart, and I'll not go into detail here just to save time. Coming to the patient scenarios now, this is a 22-year-old pregnant lady, painless lump, in the left breast for 6 months, which is static. On examination, it's a mobile, smooth, non-tender lump in the upper outer quadrant, 1.5 centimeter. Clinically node negative. Ultrasound shows it to be a well-defined lesion, likely to be a fibroadenoma. We do a core biopsy, prove it to be a fibroadenoma, and wait. So why I have put up this case is I had a patient who was 25-year-old, pregnant, had a lump right in the beginning. She was seen by her gynecologist and was told that yes, there is a lump. It is likely to increase it is a fibroadenoma and it is likely to increase during pregnancy. If it increases too much, you can come to me. But the lady did not hear the second part of the conversation. That lump went on increasing and she kept sitting on it. Towards the end of her pregnancy, in the third trimester, almost all of her breast was involved by the tumor. When by the time she was referred to us, she also had bone metastasis. And it all started with a 2-centimeter lump. On the other hand, if it is a 42-year-old lady who comes with a lump, we will not only ask for ultrasound, but also a mammogram. Again, here it was reported as BIRADS 3. We asked for a core biopsy and it's a benign tumor. So we are okay to observe depending on what the size of the tumor is. If it's a giant fibroadenoma beyond 5 centimeters, it's best to excise. If imaging features are suggesting that it could be a phylloides tumor, we have to excise it. Even if the core biopsy is benign, there is a discordance because phylloides tumor could be benign, borderline, or malignant. Any phylloides tumor needs to be taken out. A 45-year-old lady comes with a painful lump in the right breast of 10 days duration. There is a cyclical pain increase just before the periods. On examination, you find as a nodular breast. There is a 4-centimeter tender firm lump in the upper inner quadrant. No nodes. Mammo shows it to be BIRADS 3. And ultrasound shows there are multiple simple cysts in both the breasts, ranging from 5 mm to 4 centimeter. Now, a simple cyst, we don't really need to do anything. If the lady is symptomatic, which she is in this case, we can aspirate the cyst, and if the fluid is either clear or dirty kind of thing, we can discard the fluid. We don't even need to do a cytology. Definitely don't ask for FNAC for a simple cyst. Aspirate it. Aspiration of the fluid and cytology if it is hemorrhagic, or if the cyst had a solid component, then we must ask for an ultrasound guided biopsy from that solid component. On the other hand, a younger lady, not 45 but 42, had a painless lump. It's a discrete hard lump. Again, no nodes, but mammogram and ultrasound have shown it to be BIRADS 4C. We should do a core biopsy, and most likely it will come as malignant. BIRADS 4C means almost 50 to 90% chance of this being malignant. So to conclude, palpable masses should never be dismissed as benign without we investigate them appropriately. Imaging should always be performed before biopsy of a solid mass, because once we do a biopsy, there is ecchymosis, there is edema, and it will hamper in the interpretation of the imaging. So if we have asked for a mammogram and ultrasound has been recommended, please do it before doing a biopsy. If after doing ultrasound we realize the need for MRI also, please do MRI before we ask for a biopsy. Otherwise, we will have to delay that imaging for almost 10 to 14 days after the biopsy is done. In younger ladies, ultrasound is a preferred modality over mammogram as the first investigation. Beyond 30 years, we should ask for a mammogram in case of a lump. MRI is usually not asked as an upfront investigation. It's more of a problem-solving investigation, or to rule out multicentric disease in case of a dense breast. Triple test, please remember triple test: clinical, radiological, pathological, and it is the standard of care for evaluating breast masses. Core biopsy is the procedure of choice, and any radiopatho discordance has to be resolved before we tell the patient to go home. Cysts can be aspirated for confirmation of their benign nature or for patient comfort, otherwise they don't need anything. And a cytology of a benign appearing non-bloody cyst fluid is not needed to be sent. Pregnant and young patients pose a diagnostic challenge because of the increased breast density during pregnancy. And the imaging also is not so helpful, especially ultrasound and mammograms may have their own challenges. And MRI in such cases is a more problem solving tool. Although MRI also has some challenges because of pregnancy related changes. Ultrasound is the modality of choice for pregnant patients. And then we go on to do even mammogram with shielding can be done. We should have a very low threshold for prompt evaluation after observation, over observation in a gravid patient. Because if we just tell them that this is nothing and it may grow, or because you are pregnant, you cannot get other things, you concentrate on pregnancy, you may end up having a pregnancy related carcinoma, which will grow very fast because of the estrogen progesterone surge during pregnancy. Surgery and surgical incisions should be well planned, keeping the future outcome and future treatment in mind. And thank you very much. This is a multidisciplinary management. We have to join hands, not only between a gynecologist and a surgeon, but with our radiologists, our pathologists, and our other oncology colleagues. Thank you very much. I'm happy to take questions if there are any.
Thank you, Dr. Vedant. It was a brilliant talk, and you have simplified the management of breast lump in such a simple language. You have nicely covered the factors behind breast cancer, like family history of cancer, age, genetic factors, BRCA genes, menstrual history, past history of breast cancer, everything. And the essence of your talk is triple test: clinical examination, radiological test, and core biopsy. And FNEC is very less used, and core biopsy is the diagnostic method of biopsy. And he has nicely elaborated that in women younger than 30 years, ultrasound is their imaging method of choice, and in women more than 30 years, mammography is the method of choice. Excellent talk. Dr. Kiran, would you like to add something?
Really excellent talk. Very beautifully and very simply he has described each and every point for the benefit of gynecologist. So everything is I mean, he has so nicely covered, nothing to add. Only thing from gynecologist point of view, because the patient comes to us first, I might like to add a different type of word which is not actually connected with this, but needs to be that. Of course, we know all the risk factors which we can't change, like genetic, familial history, and the previous things which we can't connect. But the only thing which I would like all gynecologists, because this is the Dr. Sneha has been focusing on early detection and screening. So as gynecologists, whenever we have the opportunity, I just want to leave a message for everyone. I do it in my department also. I tell everyone, because what happens, the young residents, when they are seeing the patient, they just forget to look at the breast. Hum log lower abdomen pe hi we concentrate. So I mean, I always make them force them ki once you should have a look on the breast and put a mark there that it is normal and not. And just a few things we can always advise them, because there are certain risk factors which are modifiable. I hope Dr. Vedanta will agree. Like we should always keep on focusing them and on the active life and the weight management, because the dense breast is also.
Ma'am, you are muted.
Okay, sorry. Yeah, I was just saying that I had once a sad experience of this 35-year-old women who had very dense breast, everything normal, nothing was there. And once commented that there is some heaviness and other things. We just got an ultrasound done at that age because it is advisable. Nothing came out, and thought of it as a fibroadenosis and managed without any problem. But within few months, she did not come back, though she was educated, a teacher some in the one college. And later on, she was found to be suffering with a malignancy, which was very fast growing. And in fact, with all best possible treatment, we lost it. So the thing is this, very nicely Dr. Vedanta has told the importance of these points. And so whenever we get a chance, I think we should always tell them to have exercise, weight control,
Yes.
and specifically in perimenopausal age group, when patients are taking HRT, that part has to be, I mean, always screening becomes very important. Their reproductive history is just one or two sentences. If we ask, that will give us some, that this might be having some predisposing factor. Alcohol has also become a very common fashion these days. So these are the few things which I think as a gynecologist, we can always be, but we have to be alert and aware that this problem is rising and rising in a young woman. So we should not miss that opportunity. That's what I just want to focus, because regarding the talk, he has covered excellently.
Yeah. Thank
Congratulations.
you, Dr. Yeah. Thank you,
And
Dr.
very,
Kiran.
very pertinent and very important points. Breast self-examination must be taught to everybody and should be done around 7 to 10 days after the period begins. So day 1 of cycle, and it should be done between 7 to 10 days, and preferably schedule the imaging also during the same time, because that is the time when the breasts are softest, and the imaging will also be better. Clinical examination or self-examination would also be better. One more thing that you mentioned about family history. Family history must be taken for extended family. It is not only her immediate family, her generation, her parents, both sides generation, and their grandparents on both sides, their cousins. So it's a very, very big family. And lastly, as you mentioned, lifestyle, tobacco, alcohol.
Dr. Shashi,
If
there are few
lifestyle,
questions for Dr.
Yes,
Vedant.
yes. So thank you so much, Dr. Vedant, Dr. Kiran. So the modifiable factors have been discussed: obesity, pregnancy, lactation, drinking alcohol. All these are
yes,
lifestyle management.
Just
counseling must
one
be done.
point, just one point. Breastfeeding, which has gone, I mean, still we are fighting for that. That has to be
So,
the
so we
core
have to
point.
encourage
Yes,
breastfeeding.
too much. I mean, that is really one only probably factor which can really reduce the incidence of breast cancer.
So now I'm coming to a few questions. There are lots of questions for Dr. Vedant. One question from Dr. Jyoti Agarwal: how to evaluate and what are causes of recurrent mastitis in patient of perimenopausal age group, and how many days after imagings are advised after anti-inflammatory medications?
So again, this is a very, very perplexing and a very frustrating problem. Usually recurrent mastitis like this is because of chronic mastitis, which could be chronic idiopathic granulomatous mastitis or various other, like tuberculosis. I have seen parasitic infections coming in, like filaria, tapeworm, even typhoid I have seen causing chronic mastitis. So we must do a biopsy in such cases, because sometimes with this chronic granulomatous mastitis, there is a coexisting cancer also. Now,
Okay.
anti-inflammatory steroids. So for idiopathic granulomatous mastitis, steroids are a very, very effective tool and can manage the thing very well. But it's very wide. I use the word frustrating because it's a recurring problem. Nobody knows the exact treatment and nobody knows which is the most effective treatment. But I have seen low dose steroid used over a long period of time, around 6 to 8 weeks, and tapered, works very well. Now, imaging question is when to do imaging. Imaging has to be done right in the beginning. If the patient is having an obvious infection, treat it and then do it after a couple of weeks.
Can I make a small
Another question for
comment?
you is, pardon?
I just wish to make a small comment regarding the recurrent mastitis. There is this entity of atypical mycobacterial, infections and sinuses draining. So I have a small case report on this, and you can treat them with tetracyclines, and they do extremely well with long dose, at least 21 days of tetracyclines. She had had innumerable biopsies. She had been visiting innumerable doctors. But somehow, it was only steroids and things like that which kept being given. But this really helped out, and maybe I shall share that case report on our breast committee group also. So just one thought which I thought I should add out here.
Thank you, Dr. Charu, for sharing your
Absolutely right. So if we do a biopsy for such a patient, don't send only for histopathology, send
Right.
also for gene expert, for AFP staining, and for mycobacterial culture.
Right.
These are very important.
There is another question for Dr. Vedant. What is the cutoff size for fibroadenoma for surgical treatment?
Actually, people say only giant fibroadenomas, that is beyond 5 centimeters, but that's not what I would follow. If a patient says I'm very worried and I want to take it out, I will actually take it out. After explaining that this is, you see, we can observe it, not a problem. If a patient is not compliant, because these guidelines come from Western countries, our patients sometimes don't even come for follow-up. If they are not compliant, I would remove anything beyond 3 centimeters. And I will wait only when radiology, pathology, as well as clinical examination are concordant with each other.
Thank you, Dr. Vedant.
And a perimenopausal lady detected with fibroadenoma for the first time, I think we should wait. We should at least observe and see, because after that, after menopause, it is anyways going to regress. A fibroadenoma which is calcified, no need to remove, because it's not going to grow. It's actually an involuting kind of fibroadenoma.
Thank you so much. So now we can move to our next session.
Yes.
So I introduce our two moderators for the panel discussion, Dr. Mrinalini Mani. Ma'am is founder president of Delhi Gynae Forum, Southwest, and she is a member of the FOXI committee, breast committee, and she is also a member of the breast and cervical cancer committee and multidisciplinary committee of AOGD, and executive member of both AOGD and NARCHI. And she has received many awards like APJ Abdul Kalam Excellence Award, FOXI Arogya Ambassador Certificate Award, Wonder FOXI Award. I know her personally. She is my friend for last 20 years, and she is a very, very hardworking woman. I welcome you, ma'am. And our next co-moderator is Dr. Swasti. She is a senior consultant gynae oncology. Please display her slide. Please display.
Ma'am, you can see the slides.
Let me share.
Yeah.
Let me share. Then I will be able to show her slide. She is a senior consultant in gynae oncology at Max Super Specialty Hospital, Vaishali. And her areas of interest are gynae oncology, cancer, and fertility issues in breast cancer. And you know, her, it is showing very hazy. So I welcome you, Dr. Swasti.
Thank you, ma'am.
Panel, and over to you, Dr. Mrinalini Mani.
Yeah, I was not able to unmute myself earlier. Can we have a display of CV
Yes,
of my panelists, please?
Ma'am, those slides are with.
Ma'am, the slides are with you. Please share.
They are with Shivam. All the panelists' CVs are with Shivam, those slides.
Shivam, please display.
Is Shivam sharing the slides or?
We had just seen Dr. Anita's slide actually. Wonder what is the problem?
I think they are in the same presentation, ma'am.
Dr. Mrinalini, you have to share you share your PPT. You must be having their slides.
Shall we introduce ourselves otherwise?
Or otherwise, You are please unmute yourself, Dr. Mrilanini.
Yeah, meanwhile, I don't know, I'm getting muted in between. The host was supposed to share the slides, all of them. So we did not incorporate in our PPT. Anyway, so we will.
Dr. Manish, you can introduce by name only.
Yeah, so we will be introducing everyone by name.
I think
I request all the panelists to just introduce themselves. It will be
Yes.
fine.
Panelist, one line introduction, they can do.
Yes.
Yes. So my panelist, I have Dr. Charulata with me.
Hello.
She's one of our panelists. Dr. Charulata, can we have a brief description from your own side where you are working?
Thank you so much for having me here. I am currently the national coordinator of the Foxy Breast Committee, and I'm happy to be a part here.
Thank you very much.
Thank
Dr. Puneet Rana Arora, she's
Thank
an
you.
infertility expert with us. Dr. Puneet, we have your introduction?
Thank you. Thank you so much, ma'am. I'm a gynecologist and fertility specialist. I'm a founder and director of CFAR in Gurgaon, and I have a deep interest in oncofertility, and hence I'm here. And thank you for having me here.
Thank you very much. Dr. Renuka Gupta.
Hello, ma'am. Thank you. I'm Dr. Renuka. I am gynae oncologist at Action Cancer Hospital.
Yeah, thank you very much. Dr. Safalta, our medical oncologist. Please introduce yourself.
Hello, everyone. I am Dr. Safalta. I am Senior Consultant Medical Oncology at Max Vaishali and Noida. Thank you for having me here.
Yeah, and Dr. Sushila Gupta, ma'am, maybe have your brief introduction, although you were introduced earlier.
Yes, I am gynecologist practicing in North Delhi for the last more than 35 years. Thank you very much for having me here.
Thank you, ma'am. And Dr. Sushma Sinha, a dear friend, can you please introduce yourself?
Yeah, hi, good afternoon, and thanks for the opportunity. And yeah, I'm senior specialist at AOGD Gynae with Delhi Government Hospital.
Yeah, thank you very much. Yeah, so we begin with the panel for fertility preservation in cases of breast cancer survivors or breast cancer diagnosed patient. It's a dream of every woman to experience motherhood. And as we all know that the breast cancer has surpassed cervical cancer as being the notorious #1 cancer in the females in our country as in the world over. And the incidence being to the tune of 25 to 26 per 100,000 women, attributing to a mortality of 12 to 13 per 100,000 women. And what we see in India, is it unique to India? There's something very typical in the breast cancers we see in India. Generally, the incidence is in the elderly group of 50 plus. World over, globally, it has been seen, as so was true for our country as well. But in India, we are seeing a peak in a younger age group as well. And young girls as young as in their 25 to 35 years, the incidence is slightly increasing with every year. And what we see is these young girls, as were discussed earlier also, and Dr. Vedant had also discussed, unfortunately, we are still not screening our women properly, and they are not self-breast aware as well. So they come to us at a very late stage when they are diagnosed. The diagnosis, unfortunately, is delayed. And with the increasing changes in lifestyle, the motherhood is kept at a back burner these days. With the girls going for careers, we see more and more females opting for having their first child postponed to their 30s. And most of the ladies we see who have, young ladies who have breast cancer diagnosed and who need further treatment and maybe diagnosed at a late stage, they have not yet completed their family or are still to start their family. So because of these delayed motherhood, and the first thought which comes in the mind of a person to be when she's diagnosed with the cancer is, oh my God, the life stops there. And life comes to a full stop. And the person is just focused on getting the cancer removed and treated at the moment. And the fertility issues and everything else in life takes a back burner. So cancer should not be taken as a full stop. It's just a coma in life. And let not cancer ruin the parenthood dream. And we, unfortunately, as a gynecologist also, the lady comes to us, or the surgeons when the lady goes there, we sometimes, even the providers, we don't we forget rather, or we are not aware regarding conserving the fertility of the women. So it's a prime duty, and we should see that we all must take care when a lady is diagnosed with having a breast cancer, needing treatment, especially ongoing after surgery chemotherapy or radiotherapy. Then we have to think of these options and provide her fertility preservation. And in the panel today, we will be discussing this, that who should be taking the care of this, what are the various guidelines, and what is the way forward. Yeah, can we have the next slide, please? Dr. Swasti, now my co-moderator will take over from here, and she'll be going with the next case scenario. Dr. Swasti, please.
Thank you, ma'am. And thank you, AOGD and Foxy Breast Committee. I mean, this is something which is relevant, important, and needs to be discussed at all points in time. So we'll start off, kick off with the first case. This is a 31-year-old single and nulliparous woman with a newly diagnosed stage 1 right breast cancer, T1N0M0, ER positive, PR plus, and HER2 new negative with a Ki67 of less than 10%. She was planned for a right mastectomy and sentinel axillary lymph node biopsy, followed by possible chemotherapy, taxane-based if the nodes were positive, and tamoxifen at least for 10 years. This was an oncological plan. So she's young and unmarried. What about her fertility? This is a relevant question. So can I request Dr. Sushma to please take this up and tell us who should deal with this problem?
Actually, in the earlier talk from Dr. Vedant, it has been very nicely highlighted that the problem is increasing day by day, that the problem of unmarried females or even married ones who are delaying their pregnancies, the problem of infertility is actually increasing to a great extent. So as it was highlighted from him, that the approach should be, multidisciplinary. Like it is a case of breast cancer of a young female who's unmarried. So apart from the gynae oncologist, surgical oncologist, radiologist, and medical oncologist, it should be managed by infertility specialist, and it is actually a multidisciplinary team. But overall management is to be done by oncologist and fertility experts, infertility experts. So the gynae and surgeons, it is a teamwork, and both of them should be, combining accordingly.
Very rightly said, ma'am. It is a joint effort. We, now is the era of doing multidisciplinary approaches for management of almost all conditions, and particularly if you're dealing with cancer. So the primary care person involved, of course, in breast cancer, as we've been discussing since today afternoon, is the obstetrician gynecologist who the breast with whom the lady is seeing with a breast problem, and jointly with the oncologist and a fertility expert, and together this forms an oncofertility team. And just like we discuss in our tumor boards, this is a joint discussion where everybody is a team. And of course, now the question is fertility versus survival, what plays an important role. So everything needs to be discussed with the woman, and then based on her stage of disease and based on the prognosis and her likely survival, and of course a desire for conception, and if there are any fertility issues between the couple, whether she's married, unmarried, single, what are her likelihood, or she's having a partner. So all these things will together go hand in hand, and then we have to weigh the risk and benefits and then take a joint decision. So once we take the right steps, we just need to sit and relax. So can I request Dr. Renuka to answer this question? How does cancer treatment impact a woman's fertility?
As we all know, that the ovarian reserves are usually decreases with the age. So when a girl born, she had usually 1 million of eggs, but with the time duration, only 400 and 500 eggs are ovulated. So as the time lapse, we have usually eggs which are usually undergone apoptosis, and we don't have used these eggs. And infertility usually starts 10 years before the menopause. So already patient, a lady had the ovarian reserve decreasing with her age. So whenever we are giving a cancer treatment, it usually includes chemotherapy or the radiotherapy. So in general, when we are giving a chemotherapy having a gonadotoxins. So usually it is gonadotoxic to the ovaries. It usually accelerates the ovarian reserve loss. So it causes the ovarian functions to decrease. And if we are giving a radiotherapy to the patients, it's usually dependent on the dose of the radiotherapy. If a lady who is less than 20 years of age is a female, she can usually ovaries can at least tolerate 16.5 grays of radiation. And if she is less than 30 years of age, her ovaries can tolerate only 14 grays of the radiation. So it usually, with the age, she has a decrease ovarian reserve. With the further treatment of the chemotherapies and the radiation therapy, it usually causes germ cell damages. So usually these are the ways in which the chemotherapy and the cancer treatment usually impact her ovarian reserves.
So very rightly put, Dr. Renuka. And so in breast cancer, we are not removing the ovaries. So there's no surgical damage which is done to the ovaries. And it's only the gonadotoxicity only happens with chemotherapy. Or of course, in breast cancer, we do not expect radiation to cause damage to the ovaries because we are radiating the chest wall. So Dr. Sushila, ma'am, can I ask you a question of how does the stage of cancer impact the fertility or our decision making?
Thank you very much for the question. Definitely stage does matters. Whatever treatment plan, definitely, like Dr. Renuka has said, chemotherapy is gonadotoxins. As during this stage is a very important issue, what treatment we are going to give to the patient. But in the breast cancer, apart from the stages 1 to 3, apart from the stages, there are other important factors also which are deciding factor what treatment patient is going to take or what oncologist is going to decide, like ER/PR hormonal receptors, HER2, and general health of the patient and the growth of the rate of the growth of the cancer. And apart from that, menopausal status, whether she is in a perimenopausal or in a reproductive age group. So stage does matters, but not only stage, other factors also matters, because the treatment, whatever surgery may not affect the reproductive or fertility, but the treatment, whatever we are doing, hormone therapy as such is not gonadotoxic, but it is giving for the long time. As Dr. Renuka said, by the aging, it is also deteriorating. And hormone therapy, along with hormone if we are giving chemotherapy, that is definitely gonadotoxic. So the treatment, whatever treatment we are going to decide, that will affect whether this fertility is going to be affected or not.
Right. So I think when you're dealing with stage of cancer and whatever oncological plan has been made for this particular patient based on stage or expected clinical stage, then you cannot defer her treatment in case systemic treatment is the primary treatment. So of course, advanced cases or metastatic cases, there will be a challenge to preserve fertility, because if you need to institute systemic treatment very early and you cannot wait for at least 2 to 3 weeks, then probably that could be the challenge to initiate fertility preservation. So a joint plan has to be discussed, and an oncological clearance needs to be taken from the treating oncologist about can we safely wait for 2 to 3 weeks at least. And we'll come to how much wait when we talk to Dr. Puneet. And Dr. Charlotta, will you like to add something?
Yes, the point is that the more advanced the cancer, we know that sandwich therapy is going to be required. We know that younger the woman, sometimes the cancers are much more aggressive. And so, as you rightly mentioned just now, we might have to give her early radiation. And then, there is a big rush and a big tussle because she's still digesting the news of her cancer. And here you're talking about her fertility. So there are too many inputs going into her. And we don't want to lose important time as far as starting her treatment is concerned. And so sometimes then the fertility issue gets put on a back seat, and we probably have to prevent that, make her aware with good counseling that she has a number of options available, and then quickly proceed with the her fertility preservation, followed by her cancer treatment.
Very rightly said, ma'am. So, Dr. Safalta, can we preserve fertility in this case? And any hormonal profile would you want to be done prior to initiation of treatment?
One thing, we can certainly preserve the fertility in this patient. My part is mainly towards the dealing of the oncology part. So it is like in this patient, when we say it is ER/PR positive and Ki67 is less than 10%, that means the tumor is not that aggressive. And it is only showing T1 disease. So my take will be, when the patient is with me, I'll discuss, there are two ways to deal with it. First is we go ahead with the surgery. We do the sentinel node biopsy. If it comes out to be stage 1 only, there are ways to deal with it. We can send oncotype DX, which will tell whether she will actually need a chemotherapy or not. Oncotype DX, the TAT time is almost a month. So I'll get that 1 month. And by the time I get the oncotype DX report, I'll be able to send the patient to fertility clinic. You go and you can consult a fertility specialist to how to take care of it. Second thing,
will you be sorry to interrupt? Will you be happy in having an ovarian stimulation within that 4 months of waiting for an oncotype DX?
Ovarian stimulation, basically they use letrozole. So that will be helping an ER/PR positive itself, even if there is some complicated way of mechanism of action. But I'll be happy with that. And second thing,
but she's premenopausal.
Fine.
That's okay.
That's okay.
Okay.
Because
so, Dr. Puneet, I like your comment on this also. Now that we're discussing about assessment of this patient and surgery has been done, and Dr. Safalta wants to wait for oncotype DX report and then decide on further chemotherapy or not based on sentinel node and final nodal results. What would you want to do for her assessment at this point?
So thank you, Dr. Swasti. So I think we all agree, and I think all our co-panelists do agree that fertility discussion is very important in this particular patient, because she's 31-year-old and she needs to be given every right to preserve her fertility so that she can have a future childhood. So the other thing, like what we assess as a fertility specialist, and I think from our point of view, it's not only the assessment, it's the counseling. So even if she doesn't want to go ahead with the preservation, at least she's spoken about it and what to expect if she doesn't preserve her fertility. So both aspects should be discussed with her. So coming back to the question of assessment, I would say I would like to know her baseline ovarian reserve function test, which we generally assess by a blood test AMH, which is very simple to do it at any part of the menstrual cycle, unlike FSH, LH, which are generally done with day 2, day 3 of the period, because we don't know when the patient is going to come to us. And also we don't want to waste time waiting for the patient to have a bleed and do the ovarian reserve assessment. So we should be able to offer our treatment and counseling at every point the time she comes to us. So if I have to define one test, that will be AMH.
Right. So I think the involvement of a fertility expert should be right at the diagnosis of breast cancer. The discussions should be jointly done right from initiation of diagnosis and the initiation of treatment, because things like doing an AMH and knowing a reserve. Suppose a woman, and she's 31 already. Suppose she has a poor ovarian reserve at the onset, then probably how much would you expect out of a fertility preserving procedure? She wants to really actually go ahead and do something about it or not. That decision could, she would get that time to take that decision. So I think doing an AMH, it's not a cycle dependent thing. Like Dr. Puneet said, it's a wonderful idea. We get to know what is the kind of ovarian reserve we are looking at, and probably then post surgery in this situation, till Dr. Safalta decides for a chemotherapy, we could take this further. So
yeah, so it is high time that we have gynecologists on board, and they should be part of the tumor boards of the hospital.
Absolutely,
Like
ma'am.
some of the hospitals do have, but this message has to go across to our the medical and the surgical oncologists that yes, the gynecologist has to be on board from right from the beginning, and so that we can make aware the patients, counsel them regarding their fertility options. So that is there.
And suppose we are looking at a high risk family, with a family history, or we are looking at a BRCA positive or a BRCA mutation positive woman, then in this situation, I think the role of doing a pre-implantation genetic diagnosis for breast cancer also should be discussed between the oncology and the fertility team. Dr. Puneet, what is the kind of cost involved in a PGD in this situation, and how feasible it is and how available it is in our country at the moment?
So PGD for known genetic mutation is what we called as PGD-SR, or for monogenic diseases. It is readily available, and it's a very useful tool for the patients, especially who are carrying the genetic inherited cancers. Obviously, we cannot screen it on an oocyte. The embryo has to be generated to screen for this, which means that once a female, let's say she only preserves her egg, but when she decides to have a family, then the fertilization of an oocyte has to be done to generate an embryo. And then this test is done on an embryo before it is transferred into a female. But it is very readily available, and we've got excellent results from this. And also, if they are carrying a mutation, we don't transfer that embryo. So, the genetics, reproductive genetics is a really way forward for such patients who are carrying BRCA gene mutations.
So that's very interesting information. Dr. Mani, would you take this forward about BRCA testing? Is ma'am here? Ma'am, please unmute yourself.
Sorry. With all this background, and now we know a lady has been diagnosed with breast cancer and the decision has been taken. So Dr. Renuka, what do you think about the role of BRCA testing in all these females?
It's very interesting, ma'am, because if you know about the BRCA, usually patient who was BRCA positive usually have a high risk for the ovarian cancer also. So patient having a BRCA positive is also at a risk of ovarian cancer. So if we are doing a fertility preservation in this, every oncologist have a concern, because we usually, and even in the infertility specialists have a concern with the BRCA positive patient. If they are doing either the oocyte preservation or the ovarian cryopreservation, whatever they'll do, they are also concerned about the BRCA status of the patient, because in a patient who is BRCA positive usually have a low ovarian reserve also. It was shown in the studies that they usually have a low reserve, they usually have a low AMH level, and when they are using a stimulation cycle to these patients, they usually responded less than the BRCA negative patient. So it is very important to know the BRCA status, just to know that if she is BRCA positive, ovarian stimulation is not going to harm the breast cancer. But if we had a positive, because patient also have a some apprehension that if she is BRCA positive, maybe her daughter can have a BRCA positive test also, or the genes can carry the BRCA mutation also. So they should be counseled about the PGD. Just the Dr. Swasti said that the role of PGD. So we have a role of PGD in BRCA positive patients also. So whenever we are going to conserve the fertility or the ovarian conservation, so BRCA testing should be in a criteria. Especially in this patient, because she is a 31-year-old only. So there are certain criteria for the BRCA testing. That if patient at the less than 40 years of age, if she is a positive for breast cancer, she should underwent the BRCA testing. If patient have a bilateral breast cancer or the triple negative patient cancer in less than 60, they should usually underwent the BRCA testing. in my opinion, every patient who is underwent to the fertility preservation should underwent the BRCA testing, so that at least her doctors should know that what are the BRCA status, what should be the basically going to the stimulation cycle, and we have to give them multiple cycle for stimulation for that also. So BRCA testing is very important in these patients, according to me.
Can I just make a note though, that we do know that it is not necessary that even if you're BRCA positive, you're 100% going to get CA breast.
Exactly, ma'am.
True.
The whole idea is to, about the PGD and, we could be.
One is a high risk actually. It's a Angela Jolie effect. In fact, BRCA as positive and have your bilateral mastectomy done. But it is a high risk individual.
No, in this woman, ma'am, she already has breast cancer, na?
Yeah, this
so
she already has breast cancer.
So if we are trying to do a fertility preservation, then PGD is important for this.
Then we need to
she's
know
BRCA positive also.
BRCA status in
And
that
at only, ma'am, at very early age at the time of BRCA positive, she's only 31.
Only 30. Yeah, that's true.
Can I
Yeah,
say?
so
But Dr.
yes,
Sharma, at
please.
the same
Yes,
time,
Dr.
at the
Sushila.
same time, it is so important because this is already popular in the media, and this is a right to inform her whether she will go for BRCA testing or not. But we have to inform her about the PGT and BRCA testing also.
That's true.
This is the,
I
this
agree.
is the
Yeah.
basically message.
Yes, point well taken.
Actually, ma'am, yeah. One point is because patient is usually concerned about her children's also, na? They also wanted to know that if my genes are positive, does it affect to my child also? So it's very important to know these things also.
Renuka, you have to inform the patient and counsel regarding penetrance also. So being BRCA positive as already highlighted, so that must be a point which should be told to the patient.
Yeah,
exactly.
So
Carrying this case forward.
Before
you were
any
saying
genetic
something?
test, we need to have a genetic counseling and a
Yes.
detailed pre-test counseling and a post-test counseling has to be in place.
Yes, true. So therefore, this lady, she was referred to us for fertility preservation with an interval of 10 weeks before operation intervention. So we had this window period of 10 weeks we had where we could do everything. So, and we did a anti-Mullerian hormone. AMH was 4.51. And next slide, please, Dr. Swasti. So, Dr. Sushma, could you tell us when should we do the fertility preservation? What should be done to preserve fertility in such cases?
So after the breast malignancy has been diagnosed and the onco fertility team is on board, then we do adequate counseling to the patient, and we see what is her desire and what she wants and where does she fit in. So if she is keen for FP, fertility preservation or not, and whether she is married or is she having a steady partner, or whether she is single, and what window period do we have. So we here we have a 10 weeks window, and here we are not dealing with any pelvic surgery or any radiation in the pelvic area. So if it is a case where pelvic surgery is being done, then we need to do conservative surgeries, and if radiation is to be done, then we have to fix the ovary so that it doesn't fall into the radiation zone. But since we are dealing with breast malignancy and we are more worried about the chemotherapy, so if she says that she is married and if she has a steady partner, that means we can go for cryopreservation. Here, oocyte is taken, and after and it is preserved, and after fertilization it is preserved. But if she is unmarried, then we do take out the oocyte, and we can preserve that also. Although very few cases, it is a bit more difficult. And if suppose the window period was less than 2 weeks, then you would have gone for ovarian tissue cryopreservation. But There are other hormonal methods also by which the ovaries can be suppressed so that the chemotherapy doesn't affect the quiescent ovaries. So in this case, actually, I feel that the oocyte embryo cryopreservation and oocyte cryopreservation. Oocyte can be both of mature or immature oocytes also. Nowadays, the immature oocytes can also be preserved. So it is according to the case. The marital status has been told about this patient. What is the marital status?
She is a married woman. She's a single.
She is a single. So she'll fit into that oocyte preservation.
Yeah. Thank you very much, Dr. Sushma, for giving us elaboration on the methods available, which we'll be discussing again also in details. So Dr. Puneet, can you tell us now, she's with us, and what should the fertility team do for her fertility preservation? Can you give us a brief outline of the flow, how we should go about it?
So the first and foremost, I would say, is the counseling, because, I think somebody in my co-panelists did pointed out that it's a difficult journey for the patient if we see, getting a diagnosis of cancer is not easy. It hits hard. And at that point, if you say, okay, your fertility is going to be impaired, I'm sure that will not be taken well. And so I think the empathetic and sympathetic counseling by the oncofertility team is the important thing. And we should not press hard that, you have to preserve your fertility, even though we know that the chemotherapy of breast cancer generally falls in the moderate to severe risk for affecting the fertility. But that should be dealt in a very empathetic way. But once, and in case she doesn't decide to go ahead, she should have a plan, further follow-up plan as to what to do once she finishes her cancer treatment. But in case she wishes to go ahead, she gets a hormonal profile done. We check into what part of the menstrual cycle she is in. And then we start our stimulation for preserving her oocytes. Because in this case, she's 31-year-old, unmarried. So oocytes would be the right thing to do. Ovarian tissue, yes, we can do it, but especially for BRCA gene mutation positive patients, we generally don't recommend because that can be inherited. So, and until unless, she's okay to go ahead with the, PGD and everything afterwards. But generally for this particular patient, it will be a oocyte vitrification procedure after thorough workup, thorough ovarian reserve assessment, and then she follows her stimulation protocol. We also make sure, because we know for the breast cancer patients, we try to keep the hormones, because that's always a thing which makes us fidgety as well, that we don't want to increase her hormone levels. We don't want to increase, especially if she's positive, estrogen positive and progesterone positive cancer. So we make sure that we give her softer protocols where we keep her levels low down. So we do take all precautions and try to make it as much safe as possible for her in case she opts for it and wants to go ahead.
Yeah, thank you very much for Dr. Puneet for elaborating. And as we can see, you have mentioned, we have discussed all this in details here. And I would like Dr. Swasti to carry forward the panel from here.
I just have two things in mind. One, very rightly said by everybody that, we should not be judgmental. Maybe a 31-year-old unmarried woman doesn't bother about fertility at this point of time, and she feels that it is more important to go straight away. Her priority may be a selection of her breast cancer treatment and dealing with, if she's BRCA positive, dealing with protection from ovarian cancer as a more primary priority as compared to having a baby. So, all this should be taken with the pinch of salt, and we should be discussing and not being judgmental, but also being more empathetic and, being a partner in their journey. It's a very difficult decision, and too much information actually confuses most people and their families. Most women get confused because there's one more aspect. Suppose I was her, I would be thinking, okay, BRCA positive, let me get my second breast out, let me stimulate the ovaries, get the oocytes cryopreserved, and I don't want the ovaries back in. I want to cut down my ovarian cancer risk. Let me go for a prophylactic salpingophorectomy, and in any case, I'll see later what to do with those oocytes. So, you know, it is very difficult, and it is very, very different for every individual. So under all that information, 10 different women in the same scenario, same stage of breast cancer may decide 10 different pathways. So we need to individualize with every woman that we are dealing with, and how she takes up this journey, and what kind of journey she wants to have. So I think that's very important.
We should have the priorities straight, actually. What is her choice? And life is more important, and fertility comes later for many patients. Like you rightly said, we should not be judgmental and let her prioritize her. To summarize the first case, given that she was single with applicable time frame, a choice of oocyte cryopreservation was deemed appropriate. She was counseled about it, and she agreed to go ahead with it. And she was started on controlled ovarian stimulation as soon as possible with a random start protocol, and AIs were offered. We managed to cryopreserve 10 oocytes with her, and she's still undergoing second COS before embarking on the surgery shortly. And although chemotherapy is not yet planned, she was referred for possible long-term endocrine therapy for 10 years later on. And by the time of treatment completion, the AMH could decline further due to aging, and also that she had a borderline AMH as we had seen earlier. So the prediction of future fertility and decreased AMH levels made this fertility preservation essential in managing her condition. And she took it very well when we had discussed all these protocols and scenarios with her. However, oocyte cryopreservation could help motivate compliance to the primary treatment efficient disease, because she was very assured that her future fertility was covered, and which could be taken care of later on. So this was one thing, and this lady did definitely want to have her fertility preserved. So Dr. Sushila ma'am, can we have, what are the timing for fertility preservation? At what time should we go in for? Although we've discussed this, but can we have a brief outline again for benefit of our audience, please?
If we want fertility preservation, truly it has to be done before systemic treatment start. That can be whether it is oocyte preservation or embryo preservation or ovarian cortex, depending upon the scenario of the patient, whether we can stimulate the patient or we are having a time to stimulation. Only then we can do embryo. If patient is not having partner, or she's not married, or not having partner, or not ready for the donor, then we can do oocyte preservation depending upon the time. Even premature ovarian premature oocytes can also be preserved for IVM process. And if patient is not like, we cannot stimulate in adolescent patients or like that, where ovarian cortex can be preserved, or if we are not having time to stimulate, like less than 2 weeks before treatment has to be start, we need at least 2 weeks to stimulate the ovary, so ovarian cortex can be preserved. These are the fertility preservation procedures. And during treatment also, we can preserve the ovarian function, like shielding the pelvic organs while giving radiotherapy, or during treatment when we are giving chemotherapy, we can give GnRH agonist. They can preserve the fertility, but we should make sure that if patients want fertility preservation assurance, then we have to counsel her for the embryo or the oocyte preservation. Although patient has conceived after the chemotherapy along with GnRH agonist given by protecting the ovary, by protecting the ovarian functions, patient do conceive. But when patient is saying ki we have to preserve really fertility, then we have to counsel for that only. So during before starting the cytotoxic drug or chemotherapy drug, we should preserve fertility. During treatment, we can preserve by ovarian function. And after treatment, suppose patient has not taken fertility preservation, then after treatment also we can advise her for ovarian stimulation if there is ovarian function left there, or surrogacy or ovum donation, or whatever. If nothing can be done, then adoption can be advised.
Thank you, ma'am. Ma'am, there are 2-3 things which have just suddenly come up to me. And one is that I want to ask Dr. Safalta, this lady is 31. Now, with all the discussion that we've had, suppose she goes in for an oocyte cryopreservation, and we do the oocyte cryopreservation, and you are planning tamoxifen for 8 to 10 years. She'll be 41 by the time she'll be on tamoxifen. By what time will you allow us for an embryo transfer, if at all we are looking at, we've preserved those oocytes?
See, actually, in this patient, what I feel is that she's having just stage 1. It is a T1 disease. I'll not prescribe tamoxifen for 10 years. It will be 5 years.
Okay.
Now, if suppose, let's say the patient is 35 years of age, and then another 5 years you are saying, in that case, it is like
36,
always the
37.
oocyte preservation or cryo reimplant fertility things that will always happen after the tamoxifen course is over.
So would you like to wait for another year or two after tamoxifen is over, or straight away she can go ahead? What should be the time interval?
3 months.
3 months.
That is a washout period of tamoxifen.
Right.
Now, there are studies which are ongoing in which there are females who want pregnancy earlier. They don't want to wait for 5 years or 10 years. So in that case, there is a randomized trial which is ongoing, and we don't have the result in which like three years of tamoxifen is given and then stopped and the fertility things procedure is done. So we don't have the result yet, but yes, for this patient, I'll prescribe 5 years of tamoxifen and then pregnancy after that.
So in a hormone receptive positive breast cancer, ERPR positive, do you think pregnancy is a progesterone, it's a progesterone rich state? Will it lead to an increase or exacerbance of breast cancer recurrence?
Theoretically, yes, but we don't have this data.
We don't have data.
Yeah.
Okay. So Dr. Puneet, coming back to you, what are the costs for these? We've talked about lots of options today. What are the costs for these procedures?
So for oocyte preservation and embryo cryopreservation, it's a general IVF cost nowadays, which ranges between 1.25 lakhs to 2 lakhs, including the stimulation injections and everything. But for cancer patients, we do understand, and we have kept ourselves subsidized, and we try to get funding from the pharma companies so that we can help and support these patients. But still, I would say that oocyte cryopreservation, if we include everything, then 1.25 lakhs is the budget. We still have to get it, give it to them, which includes a year of a freezing, along with all the procedural cost, injection cost, and the freezing cost for 1 year. It's 1.25 lakhs.
And what are the subsequent annual freezing charges then?
Approximately between 30 to 40,000, depending on the number of eggs frozen, because they are frozen in straws, and each straw is pretty costly. So if it is more than 4-5 straws, it goes higher, but it's between 30 to 40,000, which is there every year.
Suppose somebody has to freeze for 5 to 7 years, it's quite a sum.
So if it is like, if it's for generally in such patients, we do encourage they undergo the long-term freezing, which is 5 years. And thankfully, the new ART Act has also kind of given us a green go that we can preserve, oocytes and embryos for 10 years.
Yes.
So somewhere down the line, they're also thinking about down the line of oncofertility, because we know these patients won't be able to use them earlier. So for now, we are kind of revising our cost, and we have come up to the number that we'll have 80,000 for 5 years, 4 years. 1 year they've already paid initially, and 4 years. So we are trying to support as much as possible to increase the uptake of fertility and help and support them in their parenthood.
And is embryo cryopreservation more expensive or less expensive as compared to oocyte cryopreservation?
So the preservation cost is same, because the liquid nitrogen which is used to preserve them is same, but it's the initial cost, which is 1.25 in the oocyte. It is 1.6 in case of embryo cryopreservation. So that's the initial cost, which is high, but the subsequent freezing cost is same.
It's same.
Yeah.
Dr. Puneet, I would like to ask you one thing here. This is something medical legal part of this. Suppose something happened, unfortunately, something happens to this lady. And so what happens to these oocytes or embryos preserved? Suppose she was married and husband wants, and the family wants that they can go in for surrogacy or something. So what does the law say about it? What is the stand? Do we have some kind of a signed documents initially when we do preserve these samples?
Yes. So that's a very, very important thing. So what at the moment we are using is what we use for our IVF patients. We do not have as such separately. So any freezing gamete, if it is frozen, it has options that they can use it for themselves. And if by any chance they're not being able to use for themselves, either they discard it or donate it to research. And so that's why we cannot donate it to anybody else, any other couple or any other needy, infertile couple. So far we cannot, but the new ART Act is coming. So we may have a little change, but so far we either discard it or we donate it to research. We cannot do anything else with that.
So husband has no claim over it. Suppose the family wants to go in for surrogacy
no. They have to go through the legal route. Yeah, they have to have a legal route. They have to take a special permission, but as such, it will not be applicable on its own.
So Dr. Charu, I would like to ask you, what is the role of counseling here then? And so how do we go about that?
Right, can somebody unmute me, please?
Yeah, sure. Ma'am, you are already unmuted.
You are unmuted. We can hear
you.
I
have actually my laptop internet connection is poor, so I have joined from.
Ma'am, so you log out of the laptop because two devices together.
Yes. I get it. I'm done. Yes, so thank you for this question. Indeed, counseling is going to play probably the most important part in this entire discussion. As we just mentioned, that the woman is still reeling from the shock of having breast cancer. And now we have to think about her fertility. Probably she doesn't even know that the treatment which she is going to be subjected to is going to affect her fertility in the future. So we need to let her know that the medication which she will probably be getting which are going to be cytotoxic. That means they're going to affect the rapidly dividing cells. And but the ovaries being one of them, she's going to probably have a problem with her fertility in the future unless we do something about it. She has to be known that her menses may get haywire. She knows that she may require special methods to conceive. She has to be dispelled of the myth that she may not, that she will be scared that she may not just be able to conceive after breast cancer. And we need to reassure her on that front that yes, there are immense studies, immense patients who have conceived well after breast cancer treatment management, and that she also has a fair chance regarding the same. There are places where the women have conceived naturally also after finishing their breast cancer treatment, and although they probably have used some fertility preservation techniques, they have not been needed to make use of those particular techniques. So counseling, I think, should start right as soon as the diagnosis is made. Probably oncosurgeons in our country do not have much time thanks to busy OPDs. So there needs to be somebody specially designated for this particular task. Of course, our fertility specialists definitely do the role, but probably we as gynecologists also need to know that these modalities are available. And that is exactly the reason why you all are having this panel discussion today. So congratulations on this great topic that you all have chosen for each and every OBGYN, where we need to know that so much can be done for each and every woman of breast cancer for her fertility. And it is not difficult for her to conceive afterwards. Probably it has been said that the chances of abortion do not increase too significantly. The chances of congenital malformations do not increase very significantly in women who have been treated for breast cancer. And so they have a reasonably good outcome even regarding their pregnancy. So all these questions she may have in her mind, and she needs to be counseled regarding each and every aspect of her future fertility and childbearing. This is what I would think.
Thank you, Dr. Charu. Like you mentioned, we need to be aware. So in Europe, we have now societies coming up, which are fertility preservation societies. They are coming up. And so hopefully in near future, people would be aware of that. I would like Dr. Swasti to carry forward the panel.
Dr. Charlotha, can I request the Foxy Breast Committee with all support to you this year and the years to come to develop some patient information leaflets collaboratively with all the joint experts for women with breast cancer if they are looking at fertility preservation, and if they could be made downloadable so that there's a standard template and they could be made in at least 1 or 2
Fantastic.
languages.
That's a great suggestion,
That's a
Dr.
brilliant
Swasti.
suggestion.
And probably it has to be done in all languages.
Yes,
And
to initiate at least English and Hindi, and probably we
yes.
could get them translated further to our Indian
Yes.
languages.
So I pray to the universe that I can take this forward. Thank you so much.
So all our best wishes to you, ma'am.
Thank you so much, Dr. Swasti. Thank you.
So Dr. Safalta and Dr. Renuka, I would like both of you to address the tumor board. How do you think tumor boards would make a difference in this situation?
When tumor boards, that constitutes both the surgical oncologist, gynec oncologist, fertility specialist, medical oncologist, radiation. So everybody is able to what will affect, because is a big issue, and the timing of fertility preservation, what all side effects the chemotherapy will be. So it will be a very good thing whenever we discuss in the tumor board about the management of the patient. We should also discuss the fertility. So specialists should be there in these tumor boards.
So thank you. And Dr. Mani, I think you can start with the second case. We're probably running short of time as well. Ma'am, please unmute yourself.
This 28-year-old married woman came to us with a preliminary diagnosis of left breast cancer upon tissue biopsy. And she had the positive axillary lymph node. She was T2N1M0. She was receptor positive, also HER2 positive, and her Ki67 were more than 20%. So she was counseled regarding the surgical modalities available to her with all the axillary node, lymph node clearance, and that it will be followed by chemotherapy, and the regimens were told to her. And the final histopathology diagnosis, immunochemistry assessment of post-surgical specimen, everything she was counseled about. And also she was counseled about regarding the possibility of further treatment for 1 year followed by tamoxifen for another 5 years. And her AMH level was low, 2.32. And can we have the next slide, please? So after this, all this, she was counseled. And I would like to ask my panelists, Dr. Charu and Dr. Safalta, although we have discussed how she should be counseled for fertility preservation, further, anything else you want to add to it regarding this particular case? Otherwise, I'll be asking Dr. Puneet what is the best option available for her. Just to summarize.
Yeah, here because she has a steady partner, we have a very clear input that she can have embryo preservation as a straightforward thing for her. And we know that the results of embryo preservations are better than oocyte preservations, and so that she will definitely have a very good chance of fertility post surgery and post treatment.
Yeah. Dr. Safalta, do you want to add anything, or Dr. Puneet can summarize the options?
One thing I want to add, actually, even when I was going through these kind of patients, I had confusion because in ER/PR positive but HER2 positive patients, we generally go with neoadjuvant chemotherapy. And here the patient is having a Ki67 of 20%. That means quite an aggressive tumor. And in that case, we want to give chemotherapy first. And we cannot wait for another like a month or so. It will be very difficult for us. So yes, 1 to 2 weeks, that is fine. But then in that case, I would like to have a method that will be like as soon as possible. And then so that I'll be able to start the treatment as early as possible.
So I think 2 weeks, if you allow, then we could probably do a random start protocol, Dr. Puneet. What do you say?
Correct.
Yes.
We can use GnRH along with the chemotherapy that will usually causing the ovarian suppression and usually preserve the fertility. These patients usually have.
Yes.
Dr. Puneet, any points from your side? Otherwise, we just move on to
so I would just want to add here, and I have a publication also which I can share with you all. I know because she's a 28-year-old woman, and we have an option of preserving an embryo, and she's in a stable relationship, which is fair enough. But I have a case, personal experience, and it has been reported in the Western literature also, and I also have an experience that there was a patient who was seeking fertility treatment, and in between got diagnosed with breast cancer. So, and she was very keen to preserve fertility. So we started her ovarian stimulation. And when she was on day 8 of stimulation, we wanted her husband to come and preserve her semen sample as a backup, which we generally do routinely in our fertility practice. And he would just hesitate to come. Come and he said that, I have some work commitment, I can't come. So we called him on 9th day, he didn't turn up. And then our whole counseling team was, after him as to, I hope everything is okay. And then finally on the 9th day evening, we got a message from him that he doesn't want to no longer go with this treatment. And he wants to give it a second thought, right? So I think obviously breast cancer for the patient, for the family, maybe it's still a social stigma. So the reproductive autonomy says that you just preserve her gametes, because if we preserve in a combined way, and let's say if her husband withdraws his consent, those embryos will go waste. So in a way, and for this particular female, we ended up preserving her oocytes because husband withdrew her consent, and then she comes for a follow-up. She's now divorced. She's into a different relationship. She wants to use her eggs. She's very happy now. So I think all these things, we can happen. So we know that, yes, embryo freezing gives us, it's more tried and tested, but now oocyte vitrification also gives us good results. So I think we should not get very much biased towards preserving embryos. We should give her reproductive autonomy and preserve her individual gametes rather than an embryo. So that's what I would like to give as a fertility specialist, a take-home message.
Yeah, point well taken. The woman
Very
should
valid
have
point.
a choice. That's her body, her choice, actually. She should be empowered for her fertility as well. And a lot of studies, as you mentioned, are going on. And it's a newer technique. We were always going for IVF. So we had embryo preservation. So with the coming generations and scenarios, coming years, we would see more of oocyte. And that would become cheaper also. The cost factor is also very important. Yeah, so just to summarize this case, she was counseled for fertility preservation because she was, all the agents would be gonadotrophic and because as she was married as well. So obstetrician for cryopreservation was an excellent choice for her, considering the today's scenario. And the treatment was 6 weeks away. So there were adequate time available with us also. So to date, she has 8 embryos cryopreserved and following the 2 cycles of conventional COS, and she's receiving chemotherapy and she plans to have a treatment in future. And her latest AMH was 0.08. So we saw that it had drastically dropped down. And she did have amenorrhea after 6 months of chemotherapy. And so at least we have, she's happy that her fertility is preserved and she has a chance later on to become pregnant and be happy in the future. And because you were very keen on experiencing motherhood. Dr. Shashi, if time permits, can we go with the next case? Or Dr. Shashi, can we go ahead with the next case? Dr. Swasti, we can quickly wind up the remaining 2 cases.
Sure, ma'am.
Yeah,
Should we go ahead?
up to 5:30. We have to wind up by 5:30.
Okay. So I think if there's anything which
Yeah,
we've not covered, we could probably,
Yes,
look at that.
but there are more 15 minutes more.
So we can discuss, just leave aside the cases, we can frankly discuss about, we've already spoken about what is the timing for pregnancy, and even if patient is going to be advised hormonal therapy, like Dr. Safalta said, washout period for tamoxifen also is about 3 months. So after completion of hormonal therapy, one has to wait for 3 months at least. And the duration of hormonal therapy is usually decided by the oncology team based on her final staging. So that's about it. And this is just a sum up of the case. So Dr. Puneet, what is the importance of a quality control of a fertility lab? Where should women go and seek fertility preserving procedures? What should they look at, or what should gynecologists or oncologists look at when they're referring the patients for a fertility preservation?
Yeah. So thank you, Dr. Swasti, on touching on it. It's a very, very important aspect of preserving fertility, because obviously we are giving hope to our women, and so it has to be frozen in an environment which is very much quality controlled. So, a dedicated fertility center labs with proper air handling units, with the proper VOC, controls, volatile particles, everyday checks. It's very important. And somebody kind of making a note of the freezing protocols, because vitrification is the current era we use for freezing. There used to be a slow freezing method, and there used to be there's a vitrification. We now know that because of the advancements that vitrification is better, which is a fast way of freezing. So we have special medias for it and special techniques for it. So we should have a lab personnel, the embryologist, the fertility specialist, all kind of well versed with this protocol, so that we can genuinely give our patients hope what they're looking for. So yes, a good lab is a key to offering a fertility preservation services.
Yeah. So just to summarize today's discussions, right from the time of the diagnosis of the cancer to her fertility planning treatment, there's so much of importance of we handhold the patient right from diagnosis till the follow-up is there, and we do not desert her in between. And we have to be in a team. The team has to go forward, and all the oncofertility multidisciplinary team should be on board right till the follow-up, the end of the treatment and planning of a fertility. So a lot of guidelines have come about from the ESCO and ESMO. Dr. Swasti, could you please summarize these for us, the latest recommendations which are there for fertility preservation?
Yeah, a quick recap of whatever we've discussed based on the guidelines. So this is ESMO 2020. All cancer patients of reproductive age group must receive an oncofertility counseling as early as possible in treatment planning, irrespective of type and stage of disease, and it should be individualized. It should be patient or couple based, or disease or treatment related factors must be taken into account. The age of the woman has to be taken into account, and a written information about oncofertility counseling should be provided. And that's where I requested Dr. Charulata to step in as the Foxy Breast Committee should take this up. There should be no absolute threshold of exposure to anti-cancer therapies regarding gonadal failure, and every patient should be considered to be at risk for gonadotoxicity once on systemic therapy. And whenever you have a true 2-week treatment delay is possible, oocytes or embryos could be cryopreserved. And of course, a timely referral, counseling, and access to fertility preserving procedures is the key. And random start ovarian stimulation protocols are applied now to limit delay to starting cancer treatment. And age-related chances of having a successful pregnancy should also be always taken into account. And just a small take-home messages. Management of breast cancer women in the young adolescent group is very complex, from variant of molecular cancer subtype to requirement of cytotoxic chemotherapy and desire for fertility. Proper selection of cryopreservation type and targeted framework for pregnancy based on joint decision by an oncofertility specialist and a breast oncologist is needed to facilitate the fertility preservation treatment. And we must not ignore the role of the gynecologist, the obstetrician gynecologist, because her inputs and her access to the patient, to the woman, and the way she will counsel also is important. To date, selection of oocytes, embryos, and ovarian tissues widely available. Risk of BRCA mutation transmission must be considered in high-risk women, particularly BRCA-positive breast cancers, and PGT should be done to ensure enhanced fertility preservation outcomes. And GnRH agonist, of course, as evidence says, has not much protective effect, should not be considered as a fertility preservation option. You could use it barring much importance or effect by it. So many women will not have had a complete family, and the male partners may be either unsure or maybe unavailable whenever you're picking up a fertility preserving procedure. So this discussion was dedicated to all those women with cancer who desire to be mothers. I thank Dr. Mani for being such an excellent moderator and for mentoring and guiding all of us through and meandering through this, and all my panelists for having their wonderful inputs and insights to this discussion. And AOGD Multidisciplinary Committee and Foxy Breast Committee, Dr. Sneha and Dr. Charulata, Dr. Sushila ma'am, Dr. Sushma Sinha ma'am, also for their valuable contribution in picking up this issue, this pertinent issue, which needs to be continuously talked about till we continue to improve our services for these women. Thank you so much. We conclude this panel. Over to you, ma'am.
Thank you, Swasti. Thank you, Dr. Mrinalini Mani, for this wonderful panel discussion. You have covered all the aspects that are required for fertility preservation in a breast cancer survivor. I just want to add one thing, that we talked at large about gonadotoxicity. Another important factor is that these radio chemos which are given, they affect the target organ uterus and endometrium also. So we have to take into consideration this aspect also, because the endometrial blood flow, it gets affected, endometrial growth, it gets affected. So I was writing a chapter for a book, which was, the topic was the theories of fertility in young adolescent and adults. So I did much literature review. They talked at large about gonadotoxicity, endometrial problems, uterine problems, and the vascularity which is getting affected by these, radiation and chemotherapy. Another aspect is that the research is going on. They are doing genetic evaluation for these survivors, why some of the patients have more gonadotoxicity and more side effects of these chemo and radio, while others may not have that. And we are hopeful that in future, like we have cultures available which antibiotics are going to affect, we will have these samples, tumor samples, which we will be able to see which they are sensitive to which chemotherapy. So we are looking forward for that also. And
thank you, Dr. Anita. Let me introduce you first.
And it's okay. I just want to say that I am, I'm a proud member, a North Zone coordinator of this committee, FOXY. And I'm really thankful, Dr. Shashi, to you. And I'm really thankful to AOGD and Breast Committee for giving me this chance to participate in this webinar. And should I go ahead with my vote of thanks, dear Shashi?
Yes, you can go. Let me speak a few words about you, Dr. Anita.
Okay, thank you.
So Dr. Anita Razoria is the Vice President of Delhi Gynae Forum South, and presently she is a Senior Consultant in the Department of OBG at Hedgewar Arogya Sansthan. And she has some few major achievements like Chairperson Adolescent Health Committee, FOXY, AOGD 2021-23, Executive Member of Outreach Narchi Committee 2021. She is faculty at various international, national and state level conferences, and had been the recipient of APJ Abdul Kalam Achievers Award and Appreciation Award, Vander Foxy Award 2019, Inspiring Gynecologist of North India Award, and many other awards. And she is the editor of Foxy Endocrinology Committee newsletter also. So, Dr. Anita, you don't need an introduction. And
Thank you, Dr. Shashi.
I wish
I will need blessings of all my dear friends for Medical Disorders and Pregnancy Committee. And I wish that I can serve, Foxy and Foxians regarding that. And now I will propose a formal vote of thanks.
Let me complete one more line.
Yes.
I wish give my best wishes to Dr. Charulata for her upcoming election.
Definitely.
And
support and blessings. Thank you, Dr.
Yes. And also to Dr. Anita Razoria for her candidature for Medical Disorders Committee. And now you can give vote of thanks. Dr.
Okay. So happy Vasant Panchami, dear all, once again. I give my, it is my gratitude towards AOGD and Foxy Breast Committee, who has given us this platform to share this knowledgeable webinar with you all. And I'm really thankful to Dr. Sneha Bhoyar ma'am, who is the chairperson of Breast Committee, who has been a guiding force behind all these, informative webinars we have been conducted. And to respected Dr. Achila ma'am, who has given us platform for this multidisciplinary committee AOGD webinar. Dr. Shashi Lata Kabra and Dr. Sushila Gupta ma'am, thank you to you for conceiving this. And you have executed it so well. And I'm really thankful to respected Dr. Milinsha, who is our a guest of honor and a special guest. Thank you for gracing the occasion. And my sincere thanks once again to Dr. Sushila and Dr. Shashilata Kabra for chairing the first session so well. And speaker, Dr. Vedant Kabra, he brought to you such informative, presentation regarding how to go ahead, what to do in a case of breast lump. And I'm thankful to dear Dr. Mrinalini ma'am and Swasti for moderating the panel discussion so well. And they have covered all the aspects of fertility preservation in a breast cancer survivor. How to counsel them, what are the economical implications, how to follow them up. Thank you for that beautiful moderation, dear ma'am. And I'm really thankful to panelists also. They have been so brilliant in their inputs. And thank you to all learned panelists, Dr. Charu Lata, Dr. Sushila, Dr. Sushma Sinha, Dr. Renuka Gupta, Dr. Safalta. You have been really suffered in carrying out and giving us the messages. And Dr. Puneet Rana, beautifully highlighting how to go ahead about it. Thank you for that, those, carry home messages. And once again, I thank AOGD and Conference International, especially Shivam, for giving us this platform. And hope the recording is soon available. We will float it on the AOGD website. So over to you, Shashi, if you want to say anything further.
Yes, thank you, Dr. Anita. I can see Dr. Sneha. Ma'am, on the
Ma'am, you want to say Sneha, ma'am?
Yes, something, Dr. Sneha, Dr. Milind sir.
Yes, I just want to congratulate you all. I just want to congratulate you all, AOGD and my...
You are not audible, Dr. Sneha.
No, we can hear her.
I'm very proud of you. And hearty congratulations to all of you. I was throughout there. I was just putting it on and listening to all of you. Wonderful inputs by the panelists also. And fantastic moderation by Dr. Swasti and Dr. Mrinalini. I'm proud of you, all of you. Anita, Sushma, and all the team.
Milind sir, you want to say something?
Yes. Yeah, yes. Friends, it was really a wonderful webinar. Same like Sneha, I was listening to every part of it. Though I was conducting my OPD, I was in the car.
Yes,
it was really, it was such a nice discussion and everyone gave justice to all those questions as well. So I won't repeat the names. Once again, I will put it in the message also. But basically, I wanted to wish all the best. Yes, Anita, to Kiran, as well as Charu. Do well, because this legacy need to be carried forward for coming years to conduct good activities, as Sneha has done wonderfully well with her committee. I wish all the best. And once again, thank you very much, Shashi, for this wonderful opportunity. Thank you. Thanks a lot. Yeah.
Thank you, everyone.
Achala ma'am, Dr. Achala ma'am.
I can't see Achala ma'am is there.
Yes, ma'am is here.
Yes, ma'am is there. Yes.
And very good webinar and very good input from all of you, and all the problems of infertility and having all the problem of fertility preservation are also very well discussed in the panel. And I think I want to put it on record that Sneha has been really doing very good work in the breast committee, and Dr. Milind Shah is the I think chief coordinator for you, and this term of breast committee has been really wonderful, and all of your members. And I'm very proud that Delhi has a lot of members in your committee, and AOGD members are all very, very committed. And
yes. Thank you so much, Achala madam. Thank you so much for our association as well. And I'm very happy, we could do this program so successfully. I'm very happy that all the members are really very, very active, vibrant, and committed to. Thank you. Thanks to you especially for this program as well.
So when our AOGD members, when they are wanting to come to Foxy, I would request everybody should support them.
Thank you, ma'am. And
absolutely. Dr. Achala,
ma'am, Dr. Achala ma'am is the guiding force.
Yes, exactly. All of you should come forward to disseminate this knowledge to all the OBGYNs from the country. and I wish all the best. I always enjoy the AOGD workshops and the webinars, either virtual or the physical. Wonderfully conducted. Yeah, good, good. Thank you, Dr.
Milind sir. And I will fail in my duty if I do not say a big thank you to all delegates who have attended and made this webinar successful. So thank you, respected faculty and dear delegates. Now it's time to say bye-bye. Bye, everyone. Thank you.
Bye.